Welcome to our Level Up series part 2. We'll be talking about stroke volume cardiac output with echo and how you do the calculations themselves. I'm Dr. Sarah Murthy. I'm director of the Critical Care Ultrasound Program here at the University of Maryland Shock Trauma.
I'm Alexis Salerno. I'm an emergency medicine doctor at University of Maryland.
I'm Allison Lankford. I am a fellow in anesthesia critical care.
And an important member of our team who's not here but who will be appearing later is Hina Fatima. She's our sonographer and our chief technical expert. Allison, tell us a little bit about yourself and your training.
So I trained as a OBGYN and then completed a maternal fetal medicine fellowship, but decided to go on and do a critical care fellowship, and the anesthesia department was very kind to let me do a fellowship with them.
So I love this, using echo to manage OB. I hadn't thought of that before. So what is RecessPocus? Resuscitation ultrasound, or RecessPocus, is echo-based ultrasound to manage complex resuscitation. This series is based on the free exam, which is a focused rapid echocardiographic evaluation, which is what we do here at Shock Trauma. But in general, the main objective of RecessPocus is to give physicians tools everywhere to manage complex shock with echo and ultrasound. Here we're really talking about using a more quantitative echo because we believe there's more to echo than just global assessments.
So what's the plan? We're working on a website, a phone app that you can even use on shift if you forget a few calculations, and we're going to produce a series of YouTube videos on how to use echo at bedside, learn some useful tips, and how to measure. If you want new content or to help us, just let us know. We're widely available. Just find us on our Twitter account at RecessPocus, email us at recesspocus@gmail.com, or just comment on the video below.
So this is our second post. If you haven't done the first one, you may want to review it. If you already know how to get the VTI and the outflow tract diameter, then go ahead and watch. So why do you want to measure the stroke volume? Allie, how about you take this? How have you been able to use some of these measurements in the past or in the future too?
Yeah, so using the stroke volume is an excellent measure of volume status. And with cardiac output, as Dr. Murthy has said before, it's the most familiar assessment of cardiac function. One of the ways that I think may be useful to use this in the future for me is that when you're presented with a patient in triage that has complaints of shortness of breath, or you're evaluating for possible preeclampsia, and you're unclear if the patient is, their complaints are due to a respiratory or a cardiac etiology, one of the simple things you can do is obtain an echo. And using these measurements, we can calculate the cardiac output, we can calculate the systemic vascular resistance, and tailor our management from there.
I think the idea of looking at preeclampsia and eclampsia is awesome. I hadn't thought of that before I met you. So for this particular episode, the clinical data is essential. You need to know the heart rate, the mean arterial blood pressure, and the height and weight of the patient or the patient's BSA. You need to know the heart rate because you have to calculate the cardiac output from the stroke volume. You need to know the BSA because that's how we can calculate out the cardiac index and the stroke volume index. And if you measure it, the systemic vascular resistive index. And we need to know the MAP so we can calculate out the SVR from the cardiac output. We're assuming for the purposes of this particular episode that you already know how to measure the outflow tract diameter and the left ventricular velocity time integral, but we're going to review them super quickly right now.
So just as we learned in our first podcast, we learned to image and then measure the left ventricular outflow tract diameter, or the LVOTD, and the left ventricular velocity time integral. The LVOTD measurement is obtained in the parasternal long axis. You're going to freeze your image and zoom on the aortic valve. It's important to measure the LVOTD during systole when the aortic valve leaflets are open, and you're going to measure just inside the leaflet insertion before the dilation. You're going to measure leading edge to leading edge, and your measurement should fall between 1.8 or 2.2 centimeters depending on the BSA. Rarely should your measurement be less than 1.5 or greater than 2.8 centimeters, and if that's the case, it may be prudent to go back and look at your measurement. Patients with a higher BSA will have a higher LVOTD.
We're planning a future broadcast about tips and pitfalls with both of these two measurements. The point of these two episodes is really just to give you the basics on how you do it.
The second important measurement that we learned in the first Level Up series was the LVVTI. This is obtained in the apical 5-chamber view. This utilizes pulse wave Doppler through the aortic valve. The pulse wave gate is just placed inside the valve. You're going to measure the VTI baseline to baseline, hugging the envelope of the curve. You're going to select the largest, best envelope for your measurement. If you have several irregular waveforms, then you want to take the average of 3 to 4 beats. And most importantly, if you have a poor signal, you don't want to take the measurement because it can lead to inaccurate results.
Moving on to the calculations. The VTI and the LVOTD are used to calculate the stroke volume. The stroke volume is calculated by pi r squared, or pi times the left ventricular outflow tract diameter, divided by 2 squared times the VTI. You divide the stroke volume by the BSA to get the stroke volume index. The cardiac output, of course, is the stroke volume times the heart rate, and the cardiac index is the cardiac output divided by the BSA. The systemic vascular resistance can be calculated if you know the cardiac output and the mean arterial blood pressure. It is the MAP minus the CVP divided by the cardiac output times 80. We can assume a CVP of 10 for these purposes. We're really just trying to estimate the systemic vascular resistance. We'll go into each one of these equations in a little bit more detail. And the systemic vascular resistive index is the MAP minus the CVP divided by the cardiac index times 80. And again, you're going to assume a CVP of 10 for this. We're going to go through each one of these equations. There will be a calculation package within your ultrasound system, and then there are several online calculators which will allow you to get the stroke volume if you know the VTI and the left ventricular outflow tract diameter. The problem with the calc package on your system is it probably is not going to calculate out the stroke volume for you if you were unable to measure the LVOTD. And we talked about in the last episode how we can estimate that number. So you may need to get one of these calc packages. And then, of course, when we put our phone app, which will be any day now, you will be able to do it on that. My favorite online calculator is the Canadian Society of Echocardiography's MedMath. You like that too, right?
Absolutely.
Yeah, and if you're a diastolic function nerd, they just recently have put out a diastolic function calculator, which is awesome. The normal values for stroke volume are 70 to 140, and for stroke volume index are 34 to 47.
For stroke volume measurement, I want everyone to go back to their college physics or algebra classes. When we're thinking about stroke volume, we're really finding the volume of a cylinder. So the left ventricular outflow tract is really a tube. So you're going to find the area of that tube, which is pi times the LVOT diameter divided by 2 squared, and you're going to multiply that by the VTI. The VTI represents the height of that cylinder. So when you multiply these two together, you're going to get your stroke volume.
This is one of my favorite things about echo. It's like the nerdy part of physics before it got too complicated, like that easy, fun part of physics. And we're all nerds. That's why you're listening to us.
So cardiac output and index. So remember, when we get our stroke volume, you're going to multiply it by your heart rate to get your cardiac output. And then you want to do liters per minute. So you want to divide that by 1,000. Again, there's a couple of web pages and apps that can help do the calculations if it's unable to be done on your ultrasound machine.
Yeah, your ultrasound machine may not calculate your cardiac output because you have to have the ECG hooked up. So there's a good chance if you want cardiac output, you may need to either do it yourself or use one of these online calculators.
And then cardiac output, and then you want to find your body surface area, or BSA, and that is multiplied together is your cardiac index. The normal values for cardiac output is about 4 to 7 liters per minute. The cardiac index is about 2.8 to 4.2 liters per minute per meter squared.
So moving on to systemic vascular resistance. For this, you're going to use that cardiac output and your MAP to measure your systemic vascular resistance. So, of course, if your cardiac output measurement is wrong, your systemic vascular resistance measurement will be wrong. But the equation is the MAP minus the CVP divided by the cardiac output times 80. That's the same equation the Vigileo uses. It's the same equation your PA catheter uses. For us, for the free, I think for most people who do critical care ultrasound, you just assume 10 for your CVP. The American Society of Echo does have a sort of more complicated system where they use 3, 8, and 15 depending on the IVC diameter and collapse. I personally don't think the IVC is accurate or useful in patients who are intubated, many of whom have big dilated IVCs that are more a reflection of airway pressure. And so I strongly recommend just using 10. It makes life way easier. If you're a super nerd and you want to calculate out your systemic vascular resistive index, which honestly makes some sense because we have so many morbidly obese patients, and to kind of understand what their vascular tone is doing, it does make sense to do that. I've started doing it recently. You divide the MAP minus the CVP divided by the cardiac index times 80. You don't just divide the SVR by the BSA. That gives you a different number. So to calculate out the systemic vascular resistive index, if you're going to nerd out that way, it's the MAP minus the CVP divided by the cardiac index. The normal values for SVR are between 800 and 1200, so higher is vasoconstricted, lower is vasodilated, and for SVRI are 1970 to 2390. In general, with ultrasound, you can't get specific numbers reproducibly the way these kind of break down. So I think you need to think of things as about. So an SVR of about 800 or below, or about 1200 or higher. Allie's going to talk about a couple of the cases she's had just in the past week. Here we do the free as a consult service during rounding hours. So these are some patients that we've done just really literally within the last week. So go ahead, Allie.
So our first case is a 65-year-old male who is hypotensive after a gastrectomy.
Now, obviously there are a lot of findings on this posterior long axis. There's a big pleural effusion, but we're going to really focus on how we do this one particular measurement. To review for a second, this is the parasternal long axis. This is the left atrium, mitral valve, left ventricle. This is your aortic valve and your right ventricle up here. And how do we measure the outflow tract, Allie?
We freeze on our parasternal long axis, and as Alexis had said earlier, you really want to zoom in so that you can focus on your aortic valve. You want to make sure you're obtaining the measurement of the LVOTD during systole when the aortic valve leaflets are open, and you're going to measure just before the dilation or immediately before that bump, and you're going to measure inside, kind of within those leaflets. So in this particular case, our measurement was 2.0 centimeters.
Right in the middle of normal. And I think we said the BSA was 1.79, so that's a little bigger than you would expect, but within reasonable limits for this particular patient.
So the next part is where we're going to obtain our VTI. So we're in our apical 5-chamber view. We are placing our cursor or our pulse wave Doppler through the aortic valve, just parallel to our interventricular septum. And then we're going to hit pulse wave again in order to get our VTI that we can measure.
So this clip doesn't show where we actually measured it, but you can see the little ball that's going up and down here. You want to set that ball right inside the left ventricular outflow tract to get the pulse wave measurement where you want to measure it. And this is what we got.
This is a beautiful VTI that we measured from baseline to baseline, just hugging the envelope of that waveform, and it measured 19.6 centimeters.
It can be a little bit hard to find the baseline. We're so used to doing it now that we do it without thinking about it. There's two different ways to do it. Hina, our sonographer, she likes to use the ECG. So systole is going to be middle of the QRS to end of the T. I don't always have the ECG hooked up, so I like to use the waveform itself, and you can kind of tell where it's going, and you just drop it down to the baseline here. So all of this stuff is noise. So you want to stay tight to the VTI and kind of use where it's easiest to see and trace it down mentally, and then trace your envelope that way. So to do these calculations for case number 1.
So just to recall, our LVOTD was 2.0 centimeters and our VTI was 19.6. Our heart rate in this patient was 113 with a blood pressure of 122/78, a MAP of 92, and the BSA was 1.79. Now it's time to get out your calculators.
Just like Dora, we want you actually to get out your calculator for at least this one. So pi would be 3.14. Go ahead and divide 2 by 2 and multiply it by the VTI. Hopefully, go ahead. Yeah, hopefully this is what you got.
Yep, so you should have had 3.14 times 1 times 19.6 to give you a stroke volume of 61.544, which we rounded up to 62 milliliters. And next, we're going to calculate the SVI, which is our stroke volume divided by our BSA. So we have 62 divided by 1.79, which gives you a result of 34.63, which we rounded up to 35 milliliters per meter squared.
There are a couple of reasons to do the indexed values. I have much more of a sense, I don't know about you, Allie, or you, Alexis, I have much more of a sense of what the normals are for stroke volume index than I do for stroke volume per se. So I know that a normal stroke volume index is about 34. So I know 35 is kind of on the lower end of normal. So we have more clinical utility for the indexed values. Is that what you guys think too?
Yeah, I think I'm more accustomed with looking at the cardiac output as a whole, but when I look at the stroke volume, I actually look more at the stroke volume than the SVI.
Do you? You look at stroke volume?
Yeah.
So moving on to cardiac output.
So for this next measurement, we're going to take our stroke volume that we calculated of 62, and we're using our heart rate and BSA, and we're going to calculate our cardiac output, which is simply our stroke volume times our heart rate divided by 1,000.
Again, like literally get your calculator out and calculate this.
So you should have had 62 times 113 divided by 1,000 for a cardiac output of 7 liters per minute. And to obtain the cardiac index, you're going to take your cardiac output divided by your BSA, which is going to be 7.0 divided by 1.79 for a cardiac index of 3.9 liters per minute.
Which is high, right? So that's a high value. Mm-hmm. So now we're going to calculate our systemic vascular resistance. I do this all the time. It sounds like you don't really in the emergency room, Alexis. So I find a systemic vascular resistance to be super useful in ICU patients, maybe less so in the emergency room. In the ICU, we were trying to figure out, am I going to give another 2 liters of fluid, or am I going to start a little bit of norepinephrine? So I find it just really useful to have a sense of what the resistance is. It is kind of an added measurement, though.
So for the calculation of our systemic vascular resistance, we're going to take our mean arterial pressure minus our CVP, which we're estimating to be 10, divided by our cardiac output multiplied by 80. So in this case, we have 92 minus 10 divided by our cardiac output of 7.0 times 80, which should give you a systemic vascular resistance of 937.
Which we said was in the normal range. And then if you're interested in the systemic vascular resistive index.
Yep, you're just going to take a similar calculation, your mean arterial pressure minus your CVP, but instead you're going to divide by your cardiac index times 80.
And again, just do me a favor and actually do it, just so you do it a couple times. All right, and you get?
So you should have 92 minus 10 divided by 3.9 times 80, which is going to give you an SVRI of 1682. So in summary, we have a stroke volume of 62, a stroke volume index of 35, cardiac output of 7.0, cardiac index of 3.9, systemic vascular resistance of 937, and systemic vascular resistive index of 1,682. And Dr. Murthy put the normal values for us in the upper right-hand corner just as a reference. But this patient has a normal stroke volume, a normal cardiac index, and a normal systemic vascular resistance.
To use this clinically, we'd say that there's no role for inotropes here. We have a good ejection fraction, good right-sided function, and we have a normal cardiac output. There's no role for vasopressors. We don't look very vasoconstricted. And depending on the situation, clinically, fluid may make sense. And with the free, we do a whole bunch of other assessments about volume responsiveness and fluid tolerance. Or conversely, your stroke volume index is actually normal. So if this clinical situation is a more fluid conservative one, you may even consider removing fluid. But in this case, calculating the stroke volume and cardiac output helped us decide whether to use pressors or fluid. There will be future broadcasts on volume management. There'll be quite a few of them, actually, because that's a rapidly evolving field and it's kind of complicated. Right now, we're just talking about cardiac output and stroke volume. Moving on to case number 2.
So our next case is a 40-year-old male with cecal perforation, status post-exploratory laparotomy, right hemicolectomy, and creation of an ileostomy or colostomy. He is now post-operative day 1 and hypotensive.
Most excellent case for a free.
So again, this is our parasternal long axis. We're measuring our LVOTD, which is 2.12 centimeters in this case.
I like to have a sense of the patient's BSA before I measure that, so I sort of understand what their LVOTD is most likely to be.
Look at that color.
I know. This is why I like this measurement.
So this is our apical 5-chamber view where we're going to calculate our VTI. And in this case, the color flow helps significantly identify where you're going to place your cursor or your pulse wave Doppler in order to obtain your VTI.
Oh, look at that pretty signal. It's so pretty.
So this measured 32.1 centimeters, which is much higher than our first case.
Yeah, and this is exactly the kind of envelope you want to see. It's best if it's got this sort of white outer rim and this nice laminar flow inside. And again, you're going to take you're going to find your baseline by kind of trailing down along this outer edge of the envelope on both sides. Or if you have an ECG hooked up and you're a nerd, look at how beautifully displayed this is. Middle of the QRS to end of the T is systole. That's how you find the baseline.
So for our calculations for case 2, our LVOTD was 2.1 centimeters and our VTI was 32.0. Vital signs for this patient: the heart rate was 78, blood pressure 133/59, MAP of 86, and a BSA of 2.12. So again, get out your calculators and calculate your stroke volume.
Hopefully you got
3.14 times 1.1 times 32, which is going to give you 113 milliliters.
so high. The stroke volume is high.
And your stroke volume index is going to be your stroke volume divided by your BSA, which is 113 divided by 2.12, which gives you 53 milliliters per meter squared.
Moving on to cardiac output and cardiac index.
So we've listed the vital signs again for you at the top. You're going to calculate your cardiac index by multiplying your stroke volume times your heart rate divided by 1,000. In this case, it's 113 times 78 divided by 1,000 for a cardiac output of 8.8 liters per minute.
Also high.
And the cardiac index is simply your cardiac output divided by your BSA, which is going to be 8.8 divided by 2.12, which is 4.2 liters per minute.
It's really high.
Mm-hmm. Which the presentation was consistent with sepsis. So this all makes sense with the clinical presentation.
So calculating our systemic vascular resistance, we take our mean arterial pressure minus our CVP divided by cardiac output times 80. So we've got 86 minus 10 divided by 8.8 times 80, which gives us an SVR of 690. And if you calculate your SVRI, you take 86 minus 10 divided by 4.2, which is your cardiac index, times 80, and that gives you 1450.
Here I've written RAP. It should be CVP, but they're assessed the same way. They're both basically 10.
So to summarize case 2, we have a stroke volume of 113, an SVI of 53, a cardiac output of 8.8, cardiac index of 4.2, and an SVR of 690, and an SVRI of 1450. So our stroke volume is very high, as is our cardiac index, but on the other hand, we have a very low systemic vascular resistance.
Yeah, so this patient's MAP was actually normal. I think it was 80 when we gave you the first vital signs. So vasopressors don't make sense at this moment in time, but should the patient become hypotensive, vasopressors would make sense. Also, it's hard to imagine this patient needs more volume with a stroke volume index of 53 and a cardiac output of 4.2. Sometimes a young trauma patient or a young patient who's in septic shock needs more than that, but I think I would tend to think this patient is probably adequately resuscitated, so I would sit back on fluids with that kind of output. And we know for sure there's no reason to start epinephrine or other inotropes because our EF is normal, our right-sided function is normal, and our cardiac output is high.
And for our third and final case, we have a 65-year-old female with metastatic ovarian cancer with malignant ascites and pleural effusions.
Can't see the alpha tract very well in this one, can we?
No, so this was an extremely challenging case. I had a very difficult time obtaining the images in the parasternal long axis and as well as the apical 5.
We can't get it to play right now, but it's a bad image.
So this is just showing you that even when you're able to clean up the image just a bit, it's still not an adequate image to obtain your LVOTD.
I think it's also showing you that you can make a measurement if you want to. Like you can line up the calipers and get a number, but that just because you've gotten a measurement doesn't mean it's a correct measurement. And we can't even really see anything with the VTI. We don't have a great signal, and we know that the VTI can underestimate flow, and that's a low number, so we're not sure what that means. So both the VTI and the LVOTD were not good in this one, right?
Yeah.
So did you say you could calculate this one?
Nope. We just unfortunately weren't able to calculate any of the measurements.
And we're planning the next episode to be a little bit more of tips and pitfalls and whom you should measure it and how you can do the measurement most accurately.
And don't get discouraged if you are unable to calculate it. Some patients have more difficult windows depending on their physiology or their pathologies. Maybe that day that you're not able to see their views, maybe the next day you will, but just keep scanning.
Yeah, and I think I would be conservative at first, and then you'll gradually get better and able to do it in more patients. And the other thing I would certainly do, which I think EM is way better about than surgery, is when you first start doing it, do it in conjunction with somebody who's done it before, and see if you're getting similar VTIs to that person, if you guys are measuring the outflow tract similarly. Also, if the patient has a Vigileo in or has a pulmonary artery catheter in, you're rotating the CTICU, or have a liver transplant patient, you can try doing it and just kind of checking yourself against the catheter. The Vigileos themselves are not necessarily so accurate, but just kind of check yourself in some format until you become used to doing it and feel confident in your own measurements. So to summarize, the two echocardiographic measurements you need to get these values are the VTI and the LVOTD. Once you have those, you can calculate out the stroke volume, which is pi r squared, or pi times the LVOTD divided by 2 squared times the VTI. The stroke volume index is the stroke volume divided by the BSA. The cardiac output is the stroke volume times the heart rate to get the cardiac output, and the cardiac index is the cardiac output divided by the BSA. And the systemic vascular resistance is the MAP minus the CVP. I got it right this time. Is the MAP minus the CVP divided by the cardiac output times 80. And you're going to assume almost always a CVP of 10. I think for this particular calculation, it just doesn't matter whether it's 5, 10, or 15. You're just trying to get a sense of what the systemic vascular resistance is. And yay! You're all done with stroke volume, cardiac output, and systemic vascular resistance. Now we'll go out and measure it.
Woo!